Today we are going to talk about rheumatic diseases. These are a large group of conditions that affect the joints, muscles, and connective tissues of the body. They can be autoimmune, degenerative, inflammatory, or systemic in nature. Most people think of arthritis when they hear the word rheumatic, and that makes sense, because arthritis and joint pain are the most common ways these diseases show up. But there are more than 100 different types, and they don't just stop at the joints. They can affect mobility, cause fatigue, disturb sleep, alter body image, and even lead to organ involvement or failure. Rheumatic disease can happen to anyone, but women are more likely to be affected than men, sometimes 2 to 9 times more likely. And because we have an aging population, arthritis and related disorders are now a significant public health issue. These conditions may start suddenly or creep in slowly. They tend to follow a pattern of remission when symptoms settle down and exacerbation when symptoms flare back up. Some people experience only mild symptoms, while others deal with permanent disability. There are different ways to classify rheumatic diseases. Some involve just one joint, which we call monoarticular, while others affect many joints, which we call polyarticular. Another way to think about them is whether they are inflammatory or non-inflammatory. Osteoarthritis, for example, is non-inflammatory and covered separately. In this session, we'll focus on inflammatory rheumatic diseases. When we talk about the pathophysiology, 3 big features stand out: inflammation, autoimmunity, and degeneration. Inflammation is the immune system's way of protecting the body. It's triggered when the body detects something harmful, like a pathogen or damaged cells. Immune cells such as T and B lymphocytes are activated, antibodies are produced, and immune complexes form. Phagocytosis of these complexes produces swelling, pain, and fluid in the joints. Chemicals like prostaglandins and leukotrienes are released, which can increase or decrease inflammation. Unfortunately, enzymes like collagenase also break down collagen in the joints, which leads to further damage. In chronic inflammation, the body doesn't shut off the response even after the original trigger is gone. Instead, new inflamed synovial tissue grows. We call this pannus, and it invades cartilage and bone, eventually causing erosion and long-term destruction of the joint. Autoimmunity is another hallmark of these conditions. Here, the immune system makes the mistake of targeting its own tissues as if they were foreign invaders. The result is inflammation and destruction, not only in joints, but also in blood vessels, the lungs, the heart, and the kidneys. Certain genetic factors, specifically HLA genes, have been linked to this autoimmune process. Degeneration is the 3rd key feature. Some call it degradation because the process is metabolically active. It happens when cartilage starts to break down due to stress, hormones, genetic factors, or previous joint injuries. The stiffening of bone and the failure of cartilage create a vicious cycle of more stress and more breakdown. Clinically, the most common symptom patients report is pain, but they may also have swelling, stiffness, limited movement, weakness, and fatigue. Assessment starts with a thorough history. We ask about when symptoms began, how they've progressed, past treatments, family history, and how the patient perceives the problem. Because these conditions are often chronic, it's important to include questions about support systems and what patients know about their disease. The physical exam focuses on posture, gait, deformities, and symmetry, along with observation of how the patient functions day to day. Functional assessment means looking at what the patient can do: dressing, feeding themselves, getting in and out of a chair, and also noting the adaptations they've made without realizing it. Laboratory studies help us track inflammation and organ function. Tests include creatinine for kidney function, erythrocyte sedimentation rate, and C-reactive protein for inflammation, blood counts, uric acid for gout, anti-nuclear antibodies for autoimmune activity, rheumatoid factor, and HLA typing. Imaging such as X-rays, CT scans, or MRIs are also used to assess damage and track disease progression. Management requires both medication and non-medication strategies. Pharmacologic therapy includes salicylates like aspirin, non-steroidal anti-inflammatory drugs, disease-modifying anti-rheumatic drugs, what we call DMARDs, and corticosteroids. DMARDs can be non-biologic like methotrexate, or biologic, such as TNF inhibitors or interleukin blockers. Each medication has important nursing considerations. NSAIDs, for example, need to be taken with food and monitored for gastrointestinal irritation. Hydroxychloroquine requires eye exams to watch for vision changes. Biologics carry infection risks, so patients must be tested for tuberculosis before starting them and monitored closely while taking them. Non-pharmacologic pain management plays a big role. Heat therapy, like warm baths, moist compresses, or paraffin dips, can ease stiffness and muscle spasm. Patients often find that exercise is easier and more effective when they use heat beforehand. Other strategies include massage, acupuncture, relaxation, guided imagery, and distraction techniques. Exercise is critical for maintaining mobility and independence. Daily range of motion activities, isometric and dynamic exercises, aerobic activity, and aquatic therapy are all helpful. Programs must be individualized and adjusted based on the patient's condition each day. Analgesics can sometimes be taken before exercise to make it more tolerable. Sleep is another area that requires attention. Many patients deal with fragmented or poor quality sleep because of pain, stiffness, depression, or medication side effects. Short-term use of low-dose antidepressants like amitriptyline can help reestablish sleep cycles. Nurses also teach sleep hygiene, setting regular sleep and wake times, creating a quiet environment, avoiding caffeine and alcohol, and practicing relaxation techniques. Nursing management focuses on supporting self-care and helping patients adapt. Common nursing diagnoses include pain, fatigue, impaired mobility, self-care deficits, disturbed body image, and difficulty coping. For each of these, we use interventions that blend comfort measures, education, assistive devices, and emotional support. For example, pain can be managed with medications and non-pharmacologic methods, but also by teaching patients to set realistic goals and verbalize how pain affects their daily life. Fatigue can be reduced through pacing, sleep routines, nutrition, and activity rest scheduling. Mobility may be improved with physical therapy, safe footwear, and assistive devices. Self-care can be supported by work simplification, timing activities, and using adaptive equipment. And for body image and coping, open discussion and involving family and community resources can make a huge difference. Collaborative problems often come from the medications themselves. Long-term therapy increases the risk of complications, so monitoring lab values, teaching about side effects, and making timely adjustments are all essential parts of nursing care. For older adults, rheumatic diseases bring additional challenges. Comorbidities can mask symptoms, and decreased vision, balance issues, and memory loss may increase risks for injury or non-adherence. Some older adults may accept pain and immobility as a normal part of aging and not seek treatment. They may also resist using assistive devices, seeing them as a sign of weakness or aging rather than independence. Nurses play a vital role in reframing these perspectives and encouraging safe, effective strategies. Medication management is especially tricky in older adults because of decreased kidney function and the potential for drug accumulation and side effects. NSAIDs, for example, increase risks for ulcers and cardiovascular problems. Corticosteroid injections may provide quick relief, but repeated use can damage joints. Nurses must advocate for balanced approaches, often starting with the safest options like acetaminophen and non-drug strategies. In the end, rheumatic diseases are chronic, complex conditions that require teamwork. Nurses are at the center of that care, helping patients manage pain, maintain function, and preserve their quality of life. By blending pharmacologic therapy, non-pharmacologic strategies, exercise, sleep support, and education, we help patients live fully, even with the challenges of these diseases.